We're just waiting for record to, and there it goes.
Erin, you're good to go.
Thanks, Patrick. Hi, everyone. I am happy to introduce Alexandria Albers today on behalf of her doctoral dissertation advisor, Dr. Sophia Newcomer, who couldn't join today. Alexandria is giving her informational seminar today, and Alexandria, if you don't know her, is a first-year PhD student in public health at She's also an alum of our MPH CHIPS program, so Community Health and Prevention Sciences. And so while working on her MPH at Alexandria worked as a grad assistant with Dr. Sophia Newcomer on studies related to vaccine epidemiology and immunization services delivery. So Alexandria is continuing to do that type of work and is working on Sophia's NIH R01 that is focused on surveillance of childhood vaccine uptake in the US. Alexandria has won multiple awards as a student in our program, to include the Bertha Morton Scholarship, the Rocky Mountain Public Health Training Center Student Leader in Public Health Award, and just today found out that she was awarded a travel award to attend the Summer Institute in Biostatistics at the University of Washington this summer, which will be very fun, I'm sure. And so with that, I'll turn it over to you, Alexandria. Welcome.
Up here. All right, so yeah, very zoomed in. Hi, everyone. Thanks for attending on Zoom and in person. It's so great to see you. I know it's a busy week for everybody with MPHA and many other things going on, but I appreciate everyone making it. So as Dr. Simmons mentioned, I'm a PhD student. I'm finishing up my first year, and I'm in the phase of my dissertation proposal. So I'm working closely with Dr. Newcomer to really refine some of my methods and hopefully get a nice finished product to then invite to my future committee members to be a part of this project. So today I'll be talking to you about refining population level measures of early childhood vaccination coverage. This is my informational seminar, the first of 3. So I'm going to start with quite a bit of background. So since this is my informational seminar, I'm going to really try to put into context why I'm doing this dissertation in this project, and hopefully I'm really convinced you that we really need to do this. And then smoothly transition into my objectives, and then outline my 3 aims and what I plan on doing for the actual methods of my project. And then, of course, go over some limitations and challenges that I foresee. And then I would like to go ahead and start framing this and how I would like this work to look long-term and how it can benefit not only national levels, but state and even local levels as well. So I have to start with the early childhood immunization schedule, and it's not as nice as the one online. I made this one, but I wanted to make sure you could see it. So this schedule is really the whole foundation to my entire dissertation. And there's a couple things I want us to notice here. Do not worry about memorizing the vaccinations that you see in front of you, but one that we have an early child immunization schedule, if you didn't know. I am interested in looking at specifically vaccines that children get in the first 2 years of life. So up to 24 months old is how this is provided here. Also important to note that that children get many different vaccinations. So here we're actually seeing 10 different vaccines or vaccine series. Also important, so these little oblong boxes here represent a dose of vaccination. So children also, for most of them, except just a couple, most of these vaccine series are multi-dose series. So all of this is really important information to carry going forward. But let's talk a little bit more about why the schedule is the way that it is. So the whole goal is to promote optimal disease protection. And again, specifically, I'm talking by the time children turn 2 years old. So pretty quick, pretty young. And currently, the whole goal is to prevent against 15 vaccine preventable diseases. And this covers COVID-19 vaccine as well. So as of 2023, COVID-19 vaccine is on the early childhood immunization schedule. I'm not looking at COVID-19 just based on time-wise of the data I'll be using. So we're just gonna push COVID-19 aside, which maybe we all feel good that we can finally do that for at least 40 minutes. But also that early childhood immunization schedule is made to do a couple really important things. And the first one is balance maternal antibodies. And just quickly what that means is that children are born with a certain level of maternal antibodies for some of the vaccine preventable diseases. And research has shown that if we vaccinate too early before those antibodies start to decrease, that we actually lose a lot of vaccine efficacy. So we have to kind of know which diseases to vaccinate for and when. But we also need to pay attention to immunological priming, which I think for me, the easiest way to get this across is that in those multi-dose series, when is the best time to give that second, third, even fourth dose? All of that timing really matters to make sure once you get a vaccine, then when you get your second one, you can get an even more robust response. And then of course, trends in disease. The US is really important to consider for what the schedule is going to provide. Probably best example recently is COVID-19. It's a disease we're dealing with, so we've added that vaccination to the schedule. Few more important key elements here. So who gives these recommendations for the childhood schedule? And it's ACIP or ACIP, which is the Advisory Committee on Immunization Practices. It's composed of multiple people that have history in vaccine safety, researchers, a lot of clinicians as well. And overall, these recommendations that ACIP gives get endorsed by multiple major medical organizations. And this is actually just a few of them. There's some other, like the OBGYN organization also has a voice at this table as well. But the importance of having a unified schedule across the entire country is extremely important, not only to like medical efficiency, but also something that all providers can go to that has recommendations from people that are living in this experience with research and really able to provide that schedule so that providers don't have to do that work themselves. And probably from a public health perspective too, one of the major bonuses of having this unified schedule is that now, if a vaccine goes on the recommended schedule, it does need to be covered financially. And that means not only if you're privately insured, but also if you're under or uninsured. It falls under the Vaccine for Children or VFC program. And this program is federally funded. And it says, you know, again, if you are trying to get a vaccine on that recommended schedule and you're under 18, you should not have to pay for that. And that's been a huge component to vaccine access, at least financially. And this was a program started in 1994 officially. So with a little bit more about the VFC program too, so we've already kind of talked about this is a critical public health intervention, but you know, whether you're sold on this or not, I think it's really important to break down how much prevention early childhood vaccinations have offered. And this really great paper came out in 2014 that was put out by the CDC, where they said, okay, well, now that we have this Vaccine for Children program, we want to follow it for 20 years and really look at how much prevention these vaccinations are helping. So they actually ended up doing a cost benefit analysis from the 1994 to 2013 time period and found that early childhood vaccinations prevented over 300 million cases of severe illness, over 20 million hospitalizations, over 700,000 deaths, and over $300 billion in healthcare costs. And this was a paper that came out in 2014, which somehow is already almost 10 years ago. So especially thinking about what it's done for COVID and some of the other infectious diseases that have had some outbreaks lately, that, yeah, it's helping a lot. But to make sure that we maintain this incredible public health intervention, we really need to maintain high vaccination coverage. And this is, of course, really what's been at the forefront of a lot of the COVID pandemic, but you know, even outside of that, we just need to make sure we're maintaining in all of these early childhood vaccination coverage that we've heard of, you know, herd immunity. We really need to make sure these kids are vaccinated, but we have to actually surveil this. So the surveillance that's happening should be at national, state, and local levels. And of course, this is not a brand new idea. So the way, in case you don't know, the way that we annually track vaccination coverage in the United States is through an actual like phone survey. So it's called the National Immunization Survey, and it's no pointer. So it's actually up here, National Immunization Survey on that second line. I'm interested in that early childhood, so it's NIS child specifically. So every year, MMWR reports from the CDC come out and they say, okay, this is what vaccination coverage looks like for this age group. And they do this every year, not only at national levels, but the lowest level they go down to are state as well. But they also give coverage for socioeconomic variables as well as other household and demographic variables. So a lot of information does come out of this, but I want to really unpack what they mean by vaccination coverage. So vaccination coverage in the national estimates that we use is completed using what's called a dose counting method. So what does that mean? So if we go back to the early childhood schedule, so just to remind you, each of these oblong boxes equals a dose of vaccine that a child is recommended to get by the time they're 2 years old. And if we just take hepatitis B here at the top, that would be 3 doses of Hep B by the time they're 2. And then we can do that for all the vaccines. Hib gets a little funky because it's brand dependent, whether you get 3 or 4. And influenza has a seasonal component to it. So depending on the age of the child, 1 or 2 doses. But otherwise, we can just do a straight count of how many doses do you need by the time you're 2 years old. And that's currently how the coverage estimates are provided. But that misses some critical information. And one is that ACIP has a recommended minimum age for every single vaccine dose that is not included in the dose counting. And they also have a recommended minimum interval for each vaccine dose. That's also recommended and part of their guidelines and is why the schedule is built the way that it is. But then there's also this piece of, okay, so let's say, so if we look at DTaP, which is the third one down here, which by the way covers 3 different diseases, diphtheria, tetanus, and pertussis. So let's say a child didn't get a first dose, they didn't get the second 2 doses at any time in that first 6 months of life. But maybe they came in around 14 or 15 months and got a vaccine dose. Maybe they came in a few weeks later, got a second, and then a third, and then a 4th dose by the time they were 2 years old. So according to vaccination coverage dose counting method, this child would be considered up to date, good to go. That would be the information we have for this child. But unfortunately, the first year plus of that life, the child wasn't protected and was missing some opportunities to get vaccinated. And so as it stands right now, there's just a lot of information that we're missing about children that fall into these different patterns of vaccination. So all of this comes together to what we call schedule adherence. And that is not only if children are not on time on vaccinations, but also if they miss that minimum age or minimum interval for vaccine doses, then we would call all of this like measuring their schedule adherence. Which, if you've heard any of Dr. Newcomer's talks, this is a huge central component to our teen vaccine research, is really measuring schedule adherence in every way possible. So importance of this adherence is that we know when children fall behind on multi-dose series, they are actually more likely to fail to complete the entire series. But we also know that on-time vaccination and adherence to the recommended schedule is a great way to measure public vaccine confidence, which I think is probably becoming more and more in the forefront of a lot of our minds. And timely receipt of vaccination is a really great way to measure what we call quality immunization services delivery, which really just means, okay, if you're getting vaccines on time, then we have potentially less barriers, we have more access to vaccines. But if we're not getting vaccinations on time, maybe some of those barriers we need to think about. There are different places we can intervene on, but definitely something signaling that something's going on there. And I know vaccine hesitancy gets a lot of kind of discussion time, but there are so many other reasons why you might not be able to get a vaccine or get to a provider to get a vaccination. And the schedule adherence piece also can talk to that a lot. So if we go back to thinking about vaccination coverage, we talked about dose counting method, feeling good about that. But the second piece, which does still fall under the umbrella of dose counting, is called a combined 7 vaccine series measure. And it's pretty much exactly what it sounds like, but it's used so often in how we think about vaccination coverage estimates that I wanted to make sure we talked about it. So it is a combined measure of coverage, but over 7 different vaccine or vaccine series using a dose counting method. So these are the 7 vaccines that are accounted for in this measure. And so DTaP, poliovirus, MMR, Hep B, Hib, varicella, and pneumococcal conjugate. And then pretty much if you have all of these doses by the time you're 2 years old, you are considered up to date for this combined 7. If you're missing 1 or more of these, then you are not up to date for the combined 7. However, what you might be noticing is it's only 7. It's totally excluding rotavirus, hepatitis A, and influenza. So as of right now, we technically have 11. I would just want to acknowledge we have 11 vaccines on the schedule. That 11th is COVID. These are the other 10, and this combined 7 measure does exclude any doses of these 3 other vaccines. So if we put all of this together, so currently you open up an MMW report, you see that we are at 80% vaccination coverage for polio. Then that is just the amount of doses. Often we get a combined 7 vaccine series measure with that would talk about 7 of those. But what it's missing is nothing about minimum age, minimum dose intervals, if children initiate those vaccines late. And then of course, we're totally missing any combined measure of all of the vaccines on the schedule. And something else too, and you know, NIS, the National Immunization Survey, started in the early 90s, and MMWRs have been coming out long before the early 90s. However, even for as long as we've been measuring vaccination coverage, which has been for quite a long time, we really haven't updated how we do this. So maybe it's some time to just look at what other types of information we can get. All of this is what makes up my dissertation. Like all of these things that I would like to add that we're currently missing is how I plan on trying to refine these coverage estimates. So my objectives are to refine national childhood vaccination coverage estimate measures, but also illuminate the factors associated with how some children use the schedule and parents and how others maybe use it differently. Because if we haven't been looking at how this schedule has been used in these ways that I've mentioned so far, then we don't know which children are using what. And that's an important piece of thinking about like disease outbreaks in communities. So for my dissertation, I will be going straight to the source and using National Immunization Survey data. The data that I am using are all publicly available. There is a restricted data set that through a long process you can get access to, but everything that I need will be publicly available. It is overseen by the CDC, the National Immunization Survey, and the data source. And just to reiterate, this is an annual phone survey that gets done. And for this age group that I'm interested in, the vaccination histories are for children when they call parents for the survey, if they have children that are like 19 to 35 months at home, and those are the vaccinations that we're tracking. But a super important piece to this is that I'm only using provider verified vaccination data. So in the survey, when they're on the phone with the parent or caregiver, they ask for permission to then send their provider a survey themselves to fill it out to make sure they actually had the vaccination. So those are the data that I'll be using. And then in NIS survey, in NIS child, there's lots of different variables, socioeconomic, demographic, household variables that I'll be used to try to figure out those factors that are associated with use of the schedule. And then another important piece to think about for analysis is what we're given is the age and days that a child received each vaccine dose. So that's how I'll be doing, like, pretty much all of the analysis really comes from how old that child was when they got a vaccine dose. And then we are able to account for the complex survey design. So we do have access to weighted variables, stratification, to be able to get those national estimates. So that's very helpful. Oh, and also, in case anyone's interested in what this sample size looks like, I've provided a 2012 through 2020 sample of provider verified data. And I'm not going on further behind 2012. That's why I presented here. So, you know, as you can see, there's some variation, of course, but the lowest is around 13,000 in 2013, with the highest being in survey year of 2020, around 19,000 kids. So for my first aim, I really want to dig into that invalid dose piece, which I'll define here in just a second. So I want to identify trends in invalid dose vaccine dose administration in the US. So what does this mean? Well, we've already talked about it, and it's really an invalid vaccine dose is when you're not hitting that minimum age requirement or you're not hitting that minimum interval requirement. So just to walk you through a schematic example, we'll take DTaP as an example. So on the top here is the minimum interval. Each of these vials is a vaccine dose. So ACIP says, okay, between dose 1 and dose 2, you have to have at least 24 days. Same thing for 2 and 3, and between 3 and 4, you have to have at least 116 days. And then you have to be at least 38 days old for the first dose, 66 days for the second dose, and you can read the others for 3 and 4. And so if you don't meet these minimums, that's when ACIP say, okay, you have an invalid vaccine dose, you are not getting an appropriate immune response, and we need those doses to be repeated. So they actually are not even supposed to count. So that's kind of thinking about how I would approach this analytically, and also reminding you that we get how old a child is for every vaccine dose. So to be a little more specific, so for this first aim, I'm going to actually be doing a trend over time analysis using NIS Child over survey years 2012 through 2020, looking at children up to 2 years old. And the first thing I have to do, of course, is just descriptively figure out how much of a prevalence we have of invalid vaccine doses. But then the second part is there a trend over time? And this is where I'll be modeling from 2012 to 2020. I really want to know if my exposure is time and my outcome is invalid dose receipt. Are we getting better, worse, or staying about the same in the amount of invalid vaccine doses that children are receiving? And I'll explain why that question came up in just a second. And then lastly, and this will be a very repetitive theme throughout the other two aims, is this is where I want to ask those factors. Are there socioeconomic, demographic factors and why some children receive invalid doses and why some don't receive invalid doses? But, you know, I think this question of why do invalid doses happen? We have a schedule, we have guidance, what's going on? So I think I don't want to underplay how complex the immunization schedule really is. And I think, you know, it's nice to see it kind of broken down and color coded, but the reality of how it's worded, how providers get that information, and the fact that there's so many, the schedule changes, it can be pretty complex and get difficult quickly. I was anecdotally recently at DPHHS immunization, like annual immunization conference a couple weeks ago. And this came up over and over again about like, okay, we know the recommendations are saying this, but I have this example for this child, and we just don't understand how to vaccinate them. So this is definitely something still being talked about in local settings. And then, you know, for different reasons that the provider might know or think this, if a child is unlikely to return potentially to actually get that next vaccine dose, a provider might start to make a decision of, I'll just go ahead and vaccinate because let's say, for example, the child comes in 2 weeks before their well child visit because they're got some mild symptoms of sickness, but Because of that might miss their next well child visit, the provider might say, I'll go ahead and vaccinate now, because there's not contraindications to do that currently. So that could put you into the invalid dose category. And I think this, this one is a big one, not having what we call clinical decision support specifically for immunization. So this is something that providers use in their clinic that actually can be incorporated into their electronic health record system, that when they sit down, they're seeing a child, they can pull up what the child is due for. And so having that is extremely helpful, like right in front of you. It's actually run federally, and ACIP parameters are fed right into it. So it's really helpful to have that, but a lot of providers don't have that, or if they're not using an electronic system, you can probably see how maybe it's a barrier to either be going based on memory or having to kind of have a sheet in front of you to tell you an overview. So a lot of different reasons why that can contribute to invalid doses. But then also changes in immunization schedule. So the schedule has really stabilized in the past few years, but even in 2020, there was like a language clarification for hepatitis A. And even that little tweak is something that has to come down from ACIP, then into clinical decision support or directly to the provider. It takes time for the provider to start practicing that, and then for us to see it reflected in the MMWR reports. So maybe just because of some changes, you're now giving invalid vaccine doses. And then lastly, record scatter and complete records. Now this is one that's a huge problem in adult vaccinations. It's not as bad, it seems, for early childhood, but especially if you have a child that has multiple providers, or maybe is sometime going to one type of clinic versus another, or if the child has moved, especially across state lines, that can be really difficult. And then the provider is giving a vaccine based on limited data. So to wrap up the invalid vaccine doses, minimum age, minimum dose interval will now be incorporated in our vaccination coverage measures. And let's move on to those kids that initiate vaccinations late. And specifically, kids that initiate about a month or at least a month or so behind get kicked into this, what's called the catch-up schedule. And this is still an ACIP recommended schedule, but we now refer to it as you're being caught up, like you have a different set of parameters that we have to follow now. And they do have this schedule for up to 18 years old, but again, we'll focus on 2 and younger. So, and one thing I do want to make sure I say about the catch-up schedule is the guidance is a little difficult. It's often like 2 and 3 and 4 pages deep on the websites. It's not as clear often because usually there's a child in front of you that maybe has had a vaccine or so, and you're doing a lot of backtracking to try to figure out what's coming next. So this is definitely a schedule that it takes some time to sit and work with. And we just have never quantified, like, who's using it? Are we using it? Are kids actually being caught up on the schedule or not? So that's one reason that we're thinking about looking at it. And then also, in the DTaP example that I gave, that, that specific child had over a year of vulnerability to DTaP when maybe it wasn't necessary. So just being able to quantify how much that's happening and just to give us some insight into maybe potential vaccine preventable disease outbreaks, if they're clustering, anything like that would be important. And then, everything that I'm talking about here really today falls under this, but I think the catch-up schedule in particular is a great way to think about introducing how you look at vaccination at a clinic and facility level for quality improvement. So if you have different areas where you can see you could have intervened at this time, or maybe your population is using the schedule a lot more than you realized, it could be a really nice addition to quality improvement. So specifically, I want to quantify the prevalence of how often this catch-up schedule is actually being used in the United States. And then I am really interested in how, what kids are using the catch-up schedule, what factors are associated with that compared to ones who are getting on-time vaccinations, and just see if there are some disparities maybe we've missed, or maybe a gap that is potentially going to widen. So this one because use of the catch-up schedule, like we already thought it was probably going to be a rare outcome. But then I just did some really preliminary looking at NIS Child 2020, and it's about a 2% outcome prevalence for it. So we thought, okay, well, let's think about a combined analysis. So the plan right now is to do a combined analysis with 7 years of survey data, 2014 to 2020. For this one, I will be looking at children up until they age out of the survey, since it is catch up and they're, taking maybe longer to get vaccinated. And so as of now, so this table here is just an example of some power analysis results that I got. So my question here was, when can I have 80% power to detect these different odds ratio? And the question I asked specifically about was in children that either were privately insured or not privately insured, because we often see that associated with under vaccination. So what it came out as, to detect a 1.5 odds ratio, I would need about 2,300 kids, which actually means about 7 years of combined data I would need to look at. So that's the plan right now, but we continue digging into that and see how realistic that is. So that's my plan for trying to figure out these kids that initiate vaccinations late and get put on that vaccination catch-up schedule. And then the last aim is having a combined measure that includes everything on the schedule, which I don't know why, but I'm very excited about this. So we will be doing exactly that, is quantifying on-time vaccination of all 10 recommended vaccinations, but in one measure. So instead of that combined 7, we're going to make a combined 10 measure. And then we want to see what's associated with kids that complete all combined 10, and then ones that don't on time complete all 10. For this one, I'm primarily just going to start with looking at 1 year of data, and then again, children up to 2 years old. And that's mainly because by 2 years old, children should be up to date on all their vaccines. And just as a reminder, combined 7, these are the 7 vaccines. We were missing rotavirus, Hep A, and influenza before. The combined 10 will add those back in. And in case you're interested, how these are different, I find this really helpful and informative. So this is the most recent round of data that we've had published in MMWR. This is for kids born 2018 to 2019. So all of this first chart is just combined 7. So as you can see, like individually, we're doing pretty well on polio, Hep B, MMR. We're over that 90% for varicella. The lowest we have on this is Hib, right at 80%. But then, I mean, our combined 7 vaccine series measure is 70%, which again, this is lower because you have to be up to date on all of these vaccines to be up to date on that combined 7 measure. But then if we take a peek at the ones that are left out of this measure, the story looks a little bit different. So now we're looking at Hep A, and I broke Hep A out here by 2 different ages. This was the clarification that was given in the immunization schedule recently. ACIP, it seems like they meant for kids to be up to date by 2 years old, but it was interpreted as by 3 years old. So now they've gone back and said, no, we want them up to date by 2. So analyses will probably be broken out for a while. But anyways, so for hepatitis A, 47% were up to date by 2, 80%, that's kind of starting to align with our combined 7 individual. But influenza at 63.9%, and this one's higher. This is higher than it has been since 2011. This one's steadily increasing, but still pretty low. And then rotavirus comes in at only about 77% of coverage. And this is all dose counting method. So yeah, they're probably a little bit lower than this for on-time vaccination. So if I had to give a prediction right now, I would say the combined 10 is going to really drop that 70% full coverage of what kids are actually fully vaccinated for in the United States. All right, so now we've talked about how I'm going to incorporate these different measures to help refine vaccination coverage estimates. So again, invalid vaccine doses, children that are on the catch-up schedule, and then making that combined 10 available. But of course, I'm going to have lots of limitations and challenges. And these are just 3 that I wanted to make sure that I definitely acknowledge today. So an unfortunate fact is that the ACIP parameters come in weeks and months instead of days. So we are currently now working on a paper to get a very consistent kind of conversion, mathematical conversion out there that's accepted and widely used to say, okay, so this is how the parameters are coming in. This is how we suggest it looks if we're doing it by days, which is how children, when they're really young, are kind of are coming into clinics and being assessed anyway. So even though that is coming out, there's still a reality of it's a conversion. And the way that we are going to be defining these parameters in days might be a little bit different to how a clinician sees it, like thinks and sees about a child when they come in. It's been a month since the last time the child's been in. What does that really mean at the clinic level? And those are just some kind of decisions you're trying to make really thoughtfully. And then I feel like it depends, like it seems like you're on a certain side of survey data, which is fine. But particularly maybe even with national survey data. But we're going to have all the challenges that come with survey data. There's always a response bias. I mean, who picked up the phone, who finished the survey, who gave permission to get vaccination data from their provider. I mean, all of those might bring some bias, of course, into who's in the survey. There's also just a general kind of decline in survey response rates. So there's that to consider as well. And then our national estimates will be from weighted data. There's always potentially issues with that if we're already bringing some bias in. And then it doesn't go below, like we can't look below the state level. Like it cuts us off at state as far as what we're able to do. And so, I think there's maybe some pros to being limited in that way, but definitely something that sometimes can be a bummer. And the public data, we don't get any virality variables, which is just personally a super bummer to me, but that's okay. We just won't ask about virality, but it's just one of the other limitations. And then I've already mentioned this a couple of times, but there has been some language since 2012 that has changed in the guidelines. So we have to be really careful how we incorporate that, because just because it changes on one end doesn't mean that's reflected in what's actually happening. And then lastly, just my long-term goals, how I would like for this work to be incorporated is, of course, I want to revisit these longstanding measures that we use for vaccination coverage and really get a true picture of how we're doing nationally and at state levels. But I also really think at state immunization information systems or state IISs, they're growing in popularity, growing in what you can do with them. They're collecting, a lot of states, including Montana, are collecting really amazing data. And then you get so much more data about that state, which is great because in a national survey, especially in a rural state, you're not as represented as other states. So I think, state IIS data, or I think where it's at later on. So if we can start working with the people who are looking at coverage at the state level and incorporating these new measurements, I think that would be really helpful. And then anytime we think about quality improvement, which is already infrastructure because the VFC program requires that you have quality improvement every 5 years come into your clinic. So there's already infrastructure there to bring in some of these measurements and see what's happening in the population that you're serving at a clinic level. And with that, lots of thanks to give, lots of acknowledgements, and thank everybody for listening and coming today. And this isn't even an exhaustive list. And my future committee members that, again, I haven't officially asked, they've already helped me in many ways. So yeah, I would love to take questions. Thank you so much. Yes.
Great presentation, Alexandria. So my question, you mentioned that you were like your A1C.
you're interested in factors that might, influence invalid dose rate and that sort of thing. And you mentioned SES. What other factors are you interested in? And yeah, I'll move there.
Yeah, so, right now, I think SES definitely sticks out the most in my mind, but we're also interested in like, there's a lot of maternal variables in there too, that we're interested in: education level, race, ethnicity, which is also can in a national survey, sometimes they're not grouped appropriately, but I think those are kind of the biggest two outside of socioeconomic that we are interested in. If a child had multiple providers, that's a factor that we're interested in. And there's also another big one that I'm forgetting. Oh, facility type. So where are you getting your vaccines at? What type of facility? That is probably a really important one for all the aims.
So just to follow up from that, do you want to go to your slide where you outlined those factors that you were looking at? Because one of the things that I noticed when you were going through this, and I think this is really important to think through in terms of, no, the next one.
Oh, this
Yeah.
one. Yeah.
Why invalid doses happen. So all
Yeah.
of these are at the provider level, right? And so just being, thinking about, what's happening at the provider level, but then if you're also incorporating the individual factors, that, the opportunities for intervention or kind of thinking about those at different levels,
Yeah.
right? So they're different targets.
Mhm.
And then with the parental one, are there, in that survey, did they ask more detailed questions? Because I can imagine that some parents just choose to delay for various reasons.
So there, in some of the survey years, are some questions about that. They are not publicly available,
Okay.
which is a bummer. But otherwise, the questions about like parental decision, yeah, they're not accessible for us, or they're very vague. Yeah. And then regarding your first statement, I think that's a very important thing, like what is actually affecting invalid doses at this level and the one I'm able to ask about. And I think the one that comes up, I don't want to use the word proxy, but that's what I'm going to use right now, is the clinical decision support. And I think if we see that invalid vaccine doses are getting better over time. So clinical decision support was initiated in 2010. And so if I'm looking at 2012 to 2020, and this is, an extrapolation for sure, but it could be part of that reason if we're seeing it get better. But it's a great point. Yeah, thank you.
I have a question about the invalid doses.
Mhm.
Does it make a difference on the timing of the invalid if it's, a week too soon versus 2 weeks too soon? And if so, are you able to account for that?
So it doesn't make a difference in how they'll be classified. Now, immunologically, that's a great question. And that's actually something I'm trying to really dig into. It's been a little difficult in the way that they do those studies and measure, because there's not a lot of like consistent repeated measures of it. So I kind of have to go with the time that they chose to measure antibodies. So it's harder to get at that question, but from a data standpoint of it won't affect whether you have an invalid vaccine dose or not. Like they won't be further broken apart. Does that answer your question?
Yeah.
Okay.
Yeah.
Somewhat related question, are you aware of any studies, observational studies that have shown that there is actual increased risk to children if there is some, under vaccination compared to just check the box, they got the dose?
Yeah, so the studies that I'm familiar with are specific to, and a lot of them that I'm thinking of now have come out in response to an outbreak. And retrospectively looking, there seems to consistently be not only unvaccinated children or unvaccinated community members as a part of that, but undervaccinated as well. Now, whether that's like how the undervaccinated is defined, tends, I don't know if it's differentiated always between, I would assume it's just dose counting. Or they missed a dose is what I've seen. They do a lot of research with the last dose of DTaP. That's one that gets missed a lot, but there are studies out there, yes, that specifically say under vaccinated children equals more chance of vaccine preventable disease.
Yeah, I have a question. That was a great question, Curtis. My question is maybe less exciting, but I'm thinking about your analysis, or are probably many analyses, and how you will define your, not necessarily the answer today anyway, but I'm just thinking about like how you're going to define your outcome in each of these aims, because it seems like there are about 4,000 different ways you can do it. And like you're gonna, like maybe you'll look at like vaccine by vaccine, or probably then like the combined. And then like how do you compare for a vaccine that where there's only 2 doses versus like DTaP where there are 4. And anyway, I mean, there's not like probably a neat answer to tie in about here, but
I mean, I am willing to give it a shot.
okay.
So, I know to answer specifically the question about like each one has different requirements, which makes it's more, I'm gonna use the word fun, more fun in the coding than in the actual analysis. I think the plan will be to, you kind of just have a flag for each of them. Like you're either up to date and you have followed these criteria, or you haven't. And so I think a lot of my outcomes will end up being binary outcomes of like, you either did this, you got these doses this way, or you didn't. And then the covariates will be a lot of that multivariable piece. If that answers some of your question.
Yeah, that answers it.
Okay.
So what about at the other end? You talk about the minimum age, so what about the maximum, right? Like where does it roll over
Yeah.
to the alternate?
I love this
vaccination
question.
versus-
It only rolls over in some of them. So I love that you're embracing the complexity of this, because I really thought I wasn't selling that of the schedule. Yeah, so some of them have a maximum age, and I will have to incorporate that as like an invalid dose, which should be, the same as thinking of it in minimum intervals or minimum age. But it won't be, and I wouldn't have data following that child if it's a maximum age that is not within that survey. So I think for that, we just wouldn't know if they were getting invalid doses after a maximum age, if it's past 3 years old. And, for a lot of there's a real switch when you hit 5 of like some of the types of vaccines change just a little. So if you were to get like a DTaP at 7, that's not really appropriate. It's a little bit different of a vaccine, but we wouldn't have access to that. But for a couple that we do, we will include that invalid. Yeah, I think it's literally just a couple. And then like Hep B, there's a 1 to 3 interval you have to pay attention to. So it's lots of fun. Thank you so much. I really appreciate it. I need to do, okay.
Should we be in your office in about 10 minutes?
We've heard more about, vaccines, but I don't think it's about.
That was curious about.
I was looking for most people that survey.
The question.
Yeah, I don't know, I would like maybe there is a thing, like that it's very, it's not very cheap.